Okay. Again, to continue with our discussion, I would like to discuss with you the most common diseases of the trachea and larynx. And I am an honored to be your guest lecturer for this afternoon. Now, most common infectious diseases of the larynx is the laryngitis. It could be infectious or it could be non-infectious. But the most common is the infectious one, which is most often than not, it is viral in origin, uh, but soon bacterial invasion could take place, like Streptococcus pneumonia, influenza, and Staphylococcus aureus. The non-infectious are also common, but these are due to allergy, thermal burns of the larynx, or trauma. But most common of the non-infectious type of laryngitis is actually coming from the voice abuse. It presents with hoarseness, some throat discomfort, dry cough, globus, or something that is itchy inside the throat. Most often than not, if it is non-infectious, it is treated with voice rest. You could have antibiotic and give some inhalations, cough sedatives, analgesics, steroids, and so on. It depends on what you're thinking at the time of your diagnosis. Commonly, GERD is one of also the rising common non-infectious diseases of the larynx, which you can add on the PPIs, which you can give also. Now, laryngitis, as you can see in your direct laryngeal examination, I would like to orient yourself. This is anterior, this is posterior, okay? But when you do the laryngoscopic examination, this should be inverted, okay? This is anterior, this is this is posterior. When you do the indirect laryngoscopy, this is supposedly anterior, okay? Now, the vocal cord, as you can see here, is actually a fine, thin, fibrous structures covered with a single layer of mucosa. What you have here, if you have laryngitis, is you can have developed this kind of thickening. Some are some of the non-infectious type is also the nodule, which is born out of your voice abuse. Um, Oftentimes, the nodule is bilateral. Although some intracordial cysts of the non-infectious type could also be present, and that is why it is very important for us otolaryngologists to really examine the uh, larynx for you to be able to come up with a good diagnosis. Again, in your case, I would like you to be particular of your physical examination on how to do the direct or indirect laryngoscopy. When you will be already rotating with us, you will be taught on how are you going to do it using the dental mirror or the laryngeal mirror. Usually we use the blade number 5, the biggest mirror. Okay, moving on. Another type of infectious is acute epiglottitis, or also known as supraglottic laryngitis. These are inflammatory conditions confined to supraglottic structures like epiglottis, are epiglottic, arytenoids, and this is marked by edema of the supraglottic structures, which may obstruct the patient. No, And commonly, acute epiglottitis is caused by H influenza, which is the most common. The clinical features is rapid and abrupt in onset of progressive, sore throat, dysphagia, and some breathing problem. Dysphonia and stridor is also common in children. And when you present with this kind of, we have the suspicion of having acute epiglottitis, please be very careful to do the direct laryngeal examination. You could have fever, etc., and all those. Now, as I said, you have to be cautious of doing the examination because it could trigger up the laryngospasm. In fact, direct laryngoscopy is to be avoided when you are not so ready of doing the examination. In fact, they are recommending this examination to be at the bedside or at the operating room. But in our practice, we have to document it and just be very ready of the contingency of doing the immediate resuscitations of the patient. However, you can also do away with the examination with the uh, mirror examination, and you can proceed with the x-ray of the neck, and therein you can actually uh, see the x-ray of the patient. Now this is the typical signs of epiglottitis. Okay, so this is normal, and this is the opening. In fact, this is not really normal because there is already thickening of the uh, middle portion of the throat vocal cord. And this is one because there are some kinds of thickening here. So this is the epiglottis, and here in you do the direct examination during video laryngoscopy or indirect mirror laryngeal examination. You can see this already. With this is already the tube already in place. Okay, so moving on. Ah, yeah, right. Now, the X-ray findings for that kind of particular diseases, especially if you have already very swollen epiglottitis, you can actually see that mark here. This is the epiglottis, which is already bloated up. It's swollen, and we call it the thumb sign on the lateral X-ray view. So sometimes that's not so defined, as again you have to be clinically inclined and suspicious to come up with a good diagnosis. Okay, how are you going to treat in acute epiglottitis? Of course, you have to treat with antibiotics, steroids, hydration, IV support, oxygen support, and probably a intubation. Now, another thing is acute LTB or acute laryngotracheobronchitis. These are actually also inflammations, not only in the larynx, but includes the trachea and the bronchi. The most common viral infections are caused by parainfluenza type 1, type 2, and these are common between ages of 6 months to 3 years old. Again, the pathology here is lies in the tissue of the mucosa that swells up. It's not only the epiglottis. So the whole thing, including the tissue, subglottic area, which are swollen, the larynx, trachea, and the bronchi, which these are all swollen. This is actually very, uh, you know, life-threatening. Now, this is the showing to you the cross-sectional portion of the trachea that have a LTB. You have the normal thing, and this is already the abnormal thing. So you have already thickening of the mucosa and the smooth muscle. Okay. Now, uh, again, you have presenting symptoms. You can have fever. You could have, uh, crappy cough or hoarseness, on difficulty of breathing. And again, it is common if you have an airway problem, you can have stridor. When you say in our medical term, when you say already stridor, that would mean already and severe, acute, and impending, more aggressive treatment. Like you have to get him in my ICU or ready for intubation or tracheotomy and so on and so forth. Again, when you have already stridor, you have to be ready. Now, I just like to go a little bit lighter on uh, how LTB is going to present, because again, going back is the history and physical examinations for you to come up with your best management. Acute LTB presents with slow onset, barking cough, it sounds like very annoying. You have also some inspiratory stridor. You can have fever that is may progress in sometimes. Commonly occur in the age 5. Sometimes the patient is restless. Sometimes if you have already suprasternal retractions, that is already very, very severe. Okay? And of course, when you have already severe, you have already some hypoxia in it. Now, this is the sign when you do the X-ray examination. This is what we call the staple sign. Okay? So here can actually wide and then it tapers a little bit at the top. So that's in the anterior view. Unlike when you have epiglottitis, it's best shown in the lateral soft tissue X-ray of the neck. Okay, this one is the anterior soft tissue X-ray of the neck. Okay, so you can actually show those signs like this one. This is an acute LTB, steeple sign. So that means it's not from epiglottis, but it is down under, uh, inferior to the epiglottis. How are you going to treat? Of course, antibiotic, recipic epinephrine, you know how it's going to be done. This is an epinephrine mixed with saline and do it in a steam inhalation. Of course, you have to IV this patient and give some steroids. Now, you're going to differentiate between epiglottitis and the LTB. More or less, they are presenting with the same signs, but the commonly the etiology is different. Croup is viral, epiglottitis is bacterial. Onset is croup is slow, but epiglottitis is very acute and rapid. You have fever. Again, the differentiating uh, point here is you have hoarseness, you have muffled. You should have to know and hear one to differentiate hoarse from a muffled. Again, sitting position, because when it is swollen, you have to find position for you to be able to breathe. Okay, the epiglottic X-ray is the staple sign. Epiglottitis is the thumbprint sign on the lateral. Okay. uh, in response to antibiotic and steroids and all those management. Actually, most of the demise is actually coming from the acute epiglottitis, meaning to say death is, you know, mm, very common here because this is very acute and severe, rapidly onset. Now, another thing for non-infectious type of laryngeal diseases is laryngomalacia, which is the most common congenital anomaly of the larynx, characterized by excessive flaccidity of the supraglottic larynx, which collapse during inspiration, producing stridor. And stridor is increasing on crying and subsides when the child is placed in prone position. This will manifest usually uh, after birth and usually disappear by 2 years of age. Why? When you have a flaccid larynx, when you breathe in, meaning to say, when you inspire, this will actually collapse. And with that collapse, you have a, a narrow larynx producing some form of disturbances. When the patient cry, you can actually appreciate the difficulty of producing this kind of sound, and it will be manifested in crying. And even when the patient is just sitting down, you can actually hear the sound, the peculiar sound of that movement of air inside the larynx. And again, basing on this characteristic, um, if you are going to be very keen and do the examination, you will find what? Omega shape of the omega shape of the true vocal cord. And how is that going to reflect in your direct examination? Usually you do the direct because this baby is actually very small. You cannot just insert the mirror without being obstructed by the tongue. So usually we do by direct laryngoscopy and observe directly the the area of the larynx. So this would present with omega shape, and of course the treatment is very conservative. How is that going to do in direct laryngoscopy? You know, when you have a breathing, it's just open. But when you breathe in, you you indrone this arytenoids going in, so it will create some form of obstruction. And mind you, the epiglottis is also very floppy and try to reshape as the omega form here. So coupled with the epiglottis that is being indrone during the inhalation, coupled with the arytenoids that will be going inside, because this is very floppy and weak, it will create some form of obstructions. So that is a typical of laryngomalacia, usually in just a baby. Now, moving on to the other topic,